Respiratory failure, we go on to the acute circulatory failure. I think in most of our intensive care symposiums, pro-con debates have become the flavor. So to start this session, we have a pro-con debate again. The topic is septic shock. Do we fill the pipes up or do we just squeeze them? So we have two well-known speakers, Dr. Supradip Ghosh. He is the director and head of critical care, Fortis Escort Hospitals, Faridabad, Haryana. He is going to speak for the topic. And to counter him is Dr. Niraj Tyagi. Dr. Niraj Tyagi is a consultant at Institute of Critical Care Medicine, Sri Gangaram Hospital, New Delhi. Over to you, gentlemen.
The kind introduction. And I'd like to congratulate Pradeep and Ajit and the team of gigs for the fantastic and gala event. And I'm sure in Indian philosophy, it doesn't talk about extreme views. We talk about Majjhim Pantha, the middle path. So these extreme views came from the West. And I strongly believe in this, that give only fluid, give only vasopressors. So hopefully, me and my good friend Niraj will be speaking almost the same thing. But just, I hope at the end of this, my 8 minutes presentation, can I have the first slide, please? 8 minutes presentation, the Niraj and the audience will be convinced that only giving vasopressor is not the solution. So we need to combine both. So, back. Yeah, back. Yeah, I can do this.
This is right, this is back.
Mm-hmm. So,
This is front of
so unfortunately, we need to go for some basics. And if we know the septic shock and the macro circulatory changes which occurs in septic shock, is the first important thing is it's a vasodilatory state. So it produces a decrease in the mean systemic filling pressure. And what is mean systemic filling pressure? This is the upstream pressure for venous return. And whatever the venous return, that will be equal to the cardiac output. So there is a decrease in the mean systemic filling pressure. There will be a decrease in the venous return and hence cardiac output. So this is because of a relative hypovolemia because of vasodilatory state, or it can be because of absolute hypovolemia depending upon the underlying disease. For example, patients comes with gastroenteritis followed by septic shock. There will be a lot of volume depletion. Secondly, there is a tachycardia, and we also have septic cardiomyopathy, both LV and RV dysfunction. Alongside that, we also have microcirculatory dysfunction. Initially, when we resuscitate our patients, as we improve the macro circulation, we can do that only, microcirculation improves. But in a later stage, there is a loss of coherence between this macro circulation and microcirculation. So the goal of resuscitation is to improve the tissue perfusion, and we can do that by increasing the delivery of oxygen, either by optimizing the cardiac output, the preload and the contractility, hemoglobin and SaO2. Or we can increase the mean arterial pressure, because mean arterial pressure is the upstream pressure for the tissue perfusion. Our aim is to normalize the capillary fill time and to normalize the lactates, because these are the markers of tissue perfusion. And we can do this by 4 things. If you have any other options, let me tell you. Please tell me. We have fluids, vasopressors, sometimes blood, and inotropes. We don't have any 5th option for this. So as we know, if we give fluid, the fluid improves the mean systemic filling pressure. And if we improve the mean systemic filling pressure, the venous return curve is shifted parallelly towards the right. And thus it improves the venous return and subsequently the cardiac output. So if we give fluid bolus, that increases the mean systemic filling pressure in this fashion. Yes, vasopressors also can increase the mean systemic filling pressure just by squeezing the vessels. That can increase the stress volume. By increasing the stress volume, it can increase the mean systemic filling pressure, and it may increase the cardiac output. But there is a but. So what about the resistance to venous return, which is the second component of our venous return formula? So as the resistance increases, the venous return and cardiac output decreases. So if they are with a vasopressors, the resistance to venous return actually increases substantially. And in this fashion, the venous return curve actually goes down like this. And so vasopressors compared to fluids can have the propensity both to cause increase in the cardiac output by increasing the mean systemic filling pressure and decrease in the cardiac output by increasing the resistance to venous return. So we have to make a balance. And this is life. We have to make a balance. We cannot be extreme. What is the balance? We all know. I think my friend Niraj will be talking a lot about this. So I'll just, so we have to maintain something between hypoperfusion state and hyperperfusion state. This is from the Chennai flood. Okay, this is from Chhattisgarh. So in the central India, land is like this. So hypoperfusion leads to multiple organ failure and mortality. We have to target something like this, some optimal perfusion. Unfortunately, because of the leaky capillaries and excessive ill-judicious administration of the fluid, patient may end up in global increased permeability syndrome, abdominal compartment syndrome, and so on and so forth. So probably Niraj will be focusing a lot about this, so I'm just skipping it. Let's see the benefits of vasopressors. Now vasopressors, we all know, as I've discussed, and it has been shown in multiple small studies that it increases the venous return and cardiac output. It can also decrease the cumulative fluid volume. It can also reduce the duration of hypotension and earlier reversal of shock. But all these studies, none of them has actually used vasopressors alone. For example, let's take the refresh study. In the refresh study, patients were included in the study only after receiving 1 liter of fluid. They were given early vasopressors, or they were, the control group received the conventional treatment. What about the recent study from the sensor, this Thai group? They could find that earlier reversal of shock. Again, this study also, fluids were continued along with the vasopressors. Whereas we have a tremendous potential to decrease cardiac output, especially when we are not using fluid alongside. We have a risk of coronary, mesenteric, and digital ischemia. Vasopressors are known to produce arrhythmias, my dear friend Niraj, and it can be as high as 1/4 of the patients can develop arrhythmias, and that's very significant. And if we use adrenaline, there is the risk of hyperlactatemia. And some studies have even shown adrenaline can produce hyperglycemia. So vasopressors have got a lot of side effects, and we need to mitigate it. So we have to maintain certain in balance. We have to maintain certain balance. And I try to look into the studies which has actually looked into an interaction between vasopressors and the fluids. And I could find only 2 studies, my dear friend Niraj. One was this study where they could find that Niraj will be happy that if we use vasopressors early, the patient's the survival is better. But they could find if we use the vasopressors with a minimal fluid volume of 1/2 liter, the risk of mortality increases significantly compared to 1.7 liter and 3.7 liters. So don't give vasopressors alone. Another study I could find a more recent study that could find that if we, as the vasopressors dose increases, the mortality increases. And this increase in the mortality reduces significantly when there is a baseline fluid of around 2 liters. And this was observed over a 6 hours period. So my dear friend, Niraj, I'm not against vasopressors, but I don't think we should be squeezing our veins alone. That's not correct. So we need to be more considerate, give some fluid, and then give vasopressors. Thank you very much.
Thank you, Dr. Supradip. I now call upon Dr.
It's been whiles we are talking and speaking to ourselves. So congratulations, organizers, and thanks for having me here. And thank you, Dr. Supradip. Dada, I mean, for initial 3 minutes, I thought you are speaking for vasopressors, but then there was a bit of course correction. So can I have, yeah, thank you. So when we talk about fluids, we talk about vasopressors, the question is not who. This is my disclaimer. And much like if you see the poster, we are two very good friends who have a bit of different methods while dealing. And whatever I'm going to talk about is will have a bit of scientific basis. So before 2000, if somebody was resuscitating a patient, what we will do, we'll look what the patient is coming to me. If I suspect cholera, I'll give 3 liters. If I suspect dysentery, I'll give 1 liter. If there is a patient who is panting, looks septic, I will probably give 500 ml and start norepinephrine. This guy, with all great intentions, what he tried to do, he tried to risk certify patients, and he realized because shock was not getting adequately treated in casualty or emergency department, he said, let's do something about it, and he gave a protocol. And this changed everything. As Dr. Peter was pointing out, as Dr. Mohan Maharaj was pointing out, one size of 30 ml per kg was fitting all. So, this is a shock pathophysiology. We all understand there is no hypovolemia per se, except in those patients who are coming with GI problems. All you have is probably most of your fluid has gone into unstressed side. So, if you give fluid, what you are trying to achieve? So, by 2010, we realized that the process of having a protocolized care is good, but it was not as promising as it looked, and we arise. And this is how we arise. So most of the trials, they limited the fluid to 1 liter, and they started vasopressors. And probably this initially treating hypotension much earlier as compared to what was being done in reverse time improved the mortality, despite giving much less of fluid. And this is what is starking. If you see on the right-hand side EGDT versus on left-hand side, it is very, very obvious. Fluids do not fit all. Unless you have a patient who is having higher lactate, who is having low CVP, they use CVP, that means who have actually absolute hypovolemia, probably they are the ones where you need to give fluids. Rest, you should be giving more of vasopressors, as happened in rest of the 3 trials, and which led to probably improved mortality. And this is what is there. Dr. Supradip talked a lot about physiology, and we understand Guyton is the guy we go back to. And obviously, it is a mean systemic filling pressure that needs to come up. But in order for it to translate into stroke volume, the gradient needs to be maintained. That means if I give 500 ml of fluid, it should increase mean systemic filling pressure much more as compared to the CVP. And this is what they studied. Ciccone and all, they looked at what kind of fluid is needed. So in a typical post-operative period patient, it is 300 ml. For a septic patient, this could be maximum 500 ml to achieve the same effect. And probably if we give fluid boluses to them, and that's the way to look at resuscitation rather than giving too much of fluid. And if my fluid boluses within an hour are not giving rise to mean systolic pressure of more than 90 or a mean pressure of around 65, it's the time to consider vasopressors. Because what will happen the moment we give vasopressors, this vasodilatory shock will start to have more of compensatory phenomena. And these are the things which happens in healthy people. But when you talk about patients, as Dr. Supradip pointed out, they have more of diastolic dysfunction. A fluid bolus can actually exceed the heart ability to compensate. And your PCWP or CVP would be rising much more as compared to your mean systemic filling pressure. So it can be a worsening situation. So all these people, they did. And this is the conclusion. You look at the names there. And by 2018, this is what they concluded. They do not support concept that aggressive fluid resuscitation is crucial. First point. Second, the minimal effect is there on blood pressure, but fluid boluses can lead to a cumulative fluid positivity, and we all know how dangerous it is. It is associated with lots and lots of mortality. So, severe organ edema and delayed hemodynamics. We have enough evidence that if we do not consider, as you see in the second part, the cause of sepsis. For example, somebody is coming with wet lungs or infected lungs already, and they have hypoproteinemia, hypoalbuminemia, the mortality is going to be really bad. But what caused it is anybody's guess. But This is what I want to highlight. From IndiCaps, we have a fair number of patients in India who come to us with respiratory failure or are in sepsis and septic shock. Giving fluid to them and waiting for fluids to give rise to our hemodynamic targets will delay vasopressors and is likely to increase mortality, as we have seen in rest of the world. So let's forget what happens. These are 5 basic things. If we start norepinephrine early, it will probably correct the hypotension faster, and this is known that if you delay and hypotension persists, as was with antibiotics, for every hour of delay, the mortality worsens by 7%. Second, as Dr. Supradip pointed out, if we can get the unstressed volume back into circulation, there is hardly any need to fluid. And obviously, the whole idea of microcirculation getting affected through macrocirculation will get into picture without fluids being given from outside. If we do not give fluid from outside, obviously there will not be any fluid overload. And if there is no cumulative fluid balance, the mortality is likely to improve. And this is the same by group, which has proved repeatedly that in patients with septic shock, if we delay norepinephrine or if we delay treating hypotension, it's going to worsen. The classic fluid trial was the first one which looked into it, was more of a feasibility trial in 2022. We have a conclusive evidence from this recent paper that avoiding fluids and treating hypotension through vasopressors is something which is likely to improve your mortality and outcomes, including adverse kidney effect, which was proven in 2014 in the classic trial when they restricted fluid to boluses and started norepinephrine much early. So we are in different times. We need to progress. And if we need to progress, fluids, they need to be restricted. For example, you enjoy single malts and you enjoy your cocktails. Not everybody feels the same way, but if you have the evidence is antibiotic fluids and peripheral vasopressors. These are part of the guidelines now. So within minutes you can start, and I will conclude by this. Michel Levy under oath said this: as clinicians, we are bound to deviate from guidelines. They should not be bounding lines. And he said that we should not rigidly be following the 20 ml per kg fluid bolus. It can be harmful. The same parameters that we are using, SVV and PPV, they can give some idea about dynamic arterial elastance. It tells you probably your patient is having much less of systemic vascular resistance. You need to play more with your afterload rather than getting fixated on the preload. So this is a patient population where you can have vasopressors early. So I conclude and I rest my case. Over to you, Supradip.
Thank you. Thank you, Dr. Tyagi. Your point taken about the importance of starting early vasopressors. We have 2 minutes for rebuttal now. Dr. Pradeep.
I told you,
Sir.
me and Niraj will not be speaking the different things. We will be taking the same thing in a circuitous way, you know. And I do agree, capacity of Niraj to drink alcohol and capacity of me to drink alcohol cannot be the same. And capacity of me drinking alcohol in my younger age and capacity now is not the same. So we have to follow a personalized approach to fluid therapy. But what is more important, the goal, the clear message from this discussion should be for the younger audience is we have to follow a mix of the things and we need to monitor the things. Vasopressors are important, but it has to be combined with fluids. Sometimes with inotropes and blood transfusion. So we need to have to avoid the fluid overload, as Niraj is pointed out repeatedly, and as I also expected the same, that he will be pointing out repeatedly the same. We need to go for a multimodal monitoring. Now, for the younger audience, when to start a vasopressor in septic shock? There is a clear evidence that if the diastolic blood pressure is very, very low, the coronary perfusion gets impaired. And it has been shown in this particular study, which was done in pregnant ladies with PPH. If the diastolic blood pressure goes below 50 and the systolic blood pressure goes below 80, the chance of elevation of tropi gets elevated. There is a white pulse pressure, but I don't have any exact value what white pulse pressure, maybe around 60 or 80. If there is a white pulse pressure, it means the patient is vasodilated. And there is something called diastolic shock index. If the diastolic shock index is more than 2.3, then also a diastolic shock is nothing but heart rate divided by the diastolic blood pressure. If it is more than 2.3, this is time to start the vasopressor. The second reason to start vasopressor is once the patient has received around 1.5 or 2 liters of fluid, and still you are resuscitating the patients. Because if you start vasopressor at this stage, there is a good evidence to show that you can limit the volume, but that does not mean that you will continue only with the vasopressors and subject the patient to ischemia and arrhythmias. Yes, you start the vasopressor, squeeze the veins a little bit, increase the stress volume, and then supplement it with further fluids. And finally, always consider the right ventricular. We often forget. Right ventricle, don't forget the right ventricle. Right ventricular and left ventricular dysfunction plus or minus renal dysfunction while selecting your fluids or vasopressors early. I rest my case. I think, audience, I think you'll agree that we both are speaking the same things in a different manner. Thank you.
Thank you, Dr. Supradip. Dr. Ranveer?
There is nothing to rebut, but again, yeah, the take-home message should be very clear that most of the trials they have shown that it's not 30 ml per kg, but just 10 ml per kg, which is for a 70 kg guy would be 700 ml or close to a liter of fluid if you give it in initial 30 minutes to an hour. And if you're not getting your desired mean arterial pressure, start vasopressors. There onwards, in 2020, one guy, Dr. Supradip, and me almost worshipped Manu Balbrain along with Jane Lo Vasa. They say that the fluid bolus should be squeezed even further. So you can have a good desired effect with 200 ml of fluid bolus post 1 liter because your mean systemic filling pressure and the volume is already restored. And if you are started with vasopressors, it's gonna reduce your dependence on preload because it is getting that unstressed volume back into your circulation. So thank you, and yeah, great debate.
Niraj, I don't agree. I worship only 2 things: my wife and alcohol. No third.
Thank you. Thank you, Dr. Supradip.
You got me there.
Thank you, Dr. Ranveer. It was very nice presentation. Thank you so much, gentlemen.